Hello, everyone. This is Jeanette Gass from Iasp, and I would like to welcome you to today's webinar. Today's webinar is the first one in a series related to the 2021 Global Year about back pain. Before I introduce our speakers, I wanted to bring your attention to some information that appears on these slides. There are several ways to participate in the webinar today. After the talks, we will have a Q&A session, and you can type your questions into the Q&A area of your Zoom meeting control panel window. You can submit questions at any time that you would like. We will also be recording this webinar, and it will be available on the IASP website. You can also tweet using hashtag Global Year 2021 and follow at IASP Pain on Twitter. Now I have the pleasure of introducing our moderator, Trevor Barker. After suffering debilitating back pain for 20 years, Trevor turned to a pain management program where he learned the value of self-management from a multidisciplinary team. In 2018, Trevor volunteered with Pain Revolution to undertake community engagement. Working alongside some leading educators, Trevor has been recognized for his contribution to Pain Revolution through sharing his story of recovery and through advocating for improved services to those living with persisting or chronic pain. Now I'll turn it over to Trevor to proceed with the webinar.
Well, welcome everyone, wherever you are in the world, and I appreciate the introduction, Jeanette. We are going to have a look at self-management for low back pain tonight, which is my favourite subject, and I don't want to take up too much time talking, so I'm going to introduce each speaker. If you've got questions, then by all means post them, and I hope that we can have plenty of time for questions at the end of everyone's presentation. And I would absolutely love to introduce Toby Newton-John to everyone tonight. Toby is a clinical psychologist working in Sydney, and you would have had a chance to read his bio, but one of the things, Toby, that really grabbed my attention was that your research is about looking at social aspects and contributors to pain, and for me that is a really important aspect, and that's all I'm going to say. I'll just hand right over to you, Toby, and thank you for being part of this webinar tonight.
Thank you very much, Trevor. So should I get going? We'll go from here, or are you going to? Yep. Okay. So welcome everybody. Welcome to this this amazing capacity we have now to talk to the world, really, which is tremendous. So whatever time of the day or night it is where you are, it's 7 o'clock in the evening in Sydney here. So thank you very much and welcome everybody. I would like to just begin just by acknowledging the First Nations people in Australia here, called Acknowledgement of Country. So I'd like to acknowledge the Gadigal people of the Eora Nation, on whose ancestral lands this university campus now stands. And I'd like to pay my respects to elders both past and present, and acknowledge them as the traditional custodians of knowledge for the land on which I am. So hopefully you can see my, my screen, my slides. And so I'm going to be talking about sort of leading us off this evening and just talking broadly about what supported self-management is and why that might be an important sort of objective for us all working in the chronic pain and chronic back pain area particularly. So I would like to again, just make my disclosures, disclose my disclosures there. So this is what I want to cover. I want to talk about self-management as a concept. I want to talk about supported self-management and how that's different in some ways to self-management as we are maybe accustomed to delivering it. I want to share with you some ideas that how you might incorporate some supported self-management type activity into your clinical practice if you're a clinician. And then finishing up, depending on the time we have, with some ideas about the way ahead. So that's the plan. So thinking about self-management firstly, which kind of, I think, pretty much the bread and butter for most of us working with chronic pain as clinicians in the field. It's surprising to me when I went to the literature to see what the literature defines as self-management. It's actually, there's no agreed definition. We're all doing it, but it's hard to find an actual consensus on what self-management is. And you can see there's a couple of examples there, which are fairly non-specific and fairly kind of general. I found a definition which I think encapsulates what self-management of chronic pain is from Michael Nicholas and Fiona Blythe in Australia here. And these underlines are my underlines. But I think it's a nice way of briefly encapsulating what self-management of chronic pain is about. So start over with the patient performs tasks as opposed to what we might typically understand in a kind of medical model where the healthcare provider performs a task. So the surgeon does something, physio does something. Self-management of chronic pain is about the patient, the client, the individual with pain performing a task which is aimed at managing symptoms. So rather than aimed at relieving symptoms or curing symptoms, self-management of chronic pain is about managing symptoms, which secondly then have this kind of interference in terms of activities, mood and relationships. So self-management of chronic pain isn't just about functional activity, it's broader than that. I just look at how pain interferes in potentially any aspect of somebody's life, all aspects of somebody's life, including their mood and their relationships. So self-management as a construct, I think that definition speaks to nicely. It sort of encompasses this distinction between active coping and passive coping. And I mean, coping is a somewhat controversial term in pain science area in terms of whether is it an input or an output. But I think there's some consensus that active coping addresses that idea that the person with pain is taking some action regarding their own management, as opposed to passive coping, where there's an external agent of some kind or other which is acting upon them. And there's some epidemiological literature to suggest that people in the community who manage their pain without attending treatments, who are reporting less disability and less distress, tend to be using more active coping strategies. So it's a pretty validated notion that we're pursuing in the self-management of pain. So what's involved in self-management of pain? There's a toolbox of a range of different kind of components in a cognitive behavioral, typically cognitive behavioral self-management program. And I think some of the other speakers tonight or this morning, wherever you happen to be, will be addressing some of these as well. It's not a definitive list, but just some sort of sense of this is typically what a CBT-based program is going to incorporate to varying degrees. And we can deliver these programs in a multitude of ways. So there's a gold standard, which is the kind of full Monty, bells and whistles, multidisciplinary intensive program over 100 hours or more. But of course, you can deliver self-management interventions individually. It doesn't have to be done in a group. And I think we all discovered, somewhat to our surprise last year, that we can actually deliver these interventions through telehealth as well. Whether individually or in a group format. I think all of us as healthcare providers astonished ourselves at how possible that ended up being in all sorts of different settings. And of course, there's online self-management programs as well, where there may be a clinician sort of guided, or they may be quite standalone, so modules that the person with pain will work through themselves. So there's a range of different formats for self-management for chronic pain, chronic back pain. The evidence for this approach, as per the most recent Cochrane review from Amanda Williams and her team, found that CBT, cognitive behavior therapy, has small or very small beneficial effects for reducing pain disability and distress in chronic pain. And I think that was a kind of a bit of a disappointment for us all that we weren't seeing a stronger effect for CBT. And there was some decrement in effect from the previous Cochrane review. And so, of course, we asked, well, why might that be? Why isn't this intervention a more powerful one? And there are lots of reasons for that that might explain why we're not seeing CBT getting stronger effects. But one potential explanation for that I want to focus on with the rest of my talk really is the idea that perhaps in our chronic pain world, we focus very much on the what, the content of what we're delivering, and we haven't focused on the how enough. We haven't spent enough time to think about how we deliver the interventions that we do. And that's what supported self-management, or the supported self-management approach to chronic pain, is really about. It's really thinking about the how of chronic disease management rather than the specific content. So that's what I really want to concentrate on for the rest of this talk. So supported self-management then, there's again some definitions which again somewhat non-specific, but I think there's a couple of things that come from this. There's the supported self-management idea recognizes the knowledge, skills, and confidence of the recipients, if you like, so the clients, the patients, the people with chronic pain in this case. And supported self-management also embraces not just the health professionals, but the teams and the services within which those health professionals work. And I'll talk a little bit about that further as well. But just drilling it down, supported self-management is based on this concept of personalized care, where the emphasis is on patient choice and patient control. And just touching on before with the shift to telehealth across the world last year, where we've got to now in places that are fortunate enough, like Australia where I am, we can now give our patients, our clients, a choice. Do they want to come in for a face-to-face consultation, or do they want to do this online as a telehealth? And that's just a small example of this sort of personalized care. The individual gets a choice as to which format they would prefer, which works better for them. So sort of a small example of this personalized care idea. And then personalized care, of course, comes from a long tradition in psychological therapies, the humanistic psychology. Carl Rogers and Abraham Maslow, names that people might well know, who really emphasize the importance of all care, all therapy being client-centered. And so the supported self-management approach has picked up on that long tradition and really tried to make it relevant to the healthcare we're delivering today. So I'm not going to go through these all in sort of specific exact detail, but just to give you a sense of some of the differences between the supported self-management idea and traditional care, or perhaps the care that we may be delivering in our services at the moment. The self-management, supported self-management idea kind of has this recognition that expertise is both in a healthcare provider, but also the patient carries expertise in themselves. That the sort of the sausage factory idea that we deliver one treatment and everybody gets that same treatment because they've got the same disorder is not client-centered care. That's everything, you know, if you've got a hammer, everything looks like a nail sort of idea, isn't it? It's about shared responsibility, and that means, as we were talking earlier, about an active coping model where the patient, the client, is an active participant in their own treatment, but also the healthcare system is responsible for the outcomes here collectively, rather than individual services being involved and then dropping out, which is often what unfortunately happens. There's an empowerment idea in supported self-management, which is a different concept to just compliance or adherence to a treatment recommendation. It's actually empowering individuals to manage their health more effectively and better. And then finally, the notion that supported self-management deals with chronic disease and chronic illness and chronic pain. And so the intervention, the process needs to be long-term, because these are long-term conditions, rather than kind of treating them like they're acute and they're one-off and then we move the person onto some other part of the system. Supported self-management is about connecting the system together to provide enduring support and enduring care, for which there is good evidence that it's much more effective. So I'm just going to summarize all of that really from what I've been saying, just in a bit of a nutshell here. There's a number of shifts in a supported self-management approach from perhaps traditional healthcare provision. The first shift is a power shift, and that's the healthcare provider taking what's called sometimes a one-down position and recognizing that the person, the patient, the client in front of them is the expert on themselves. And I'm going to just spend a bit of time talking about how we can operationalize, we can actually do that in sessions to reset that power balance, if you like, between the client and ourselves. There's a responsibility shift in a supported self-management idea, which says that, yes, the person with the chronic condition is responsible for their healthcare and the adoption of active coping for that, but the healthcare system has a collective responsibility, a joined up responsibility, rather than a bounce between services sort of idea or a fall between cracks sort of idea. Supported self-management is about a cohesive healthcare system, so that individual is supported across the system rather than one-offs, which are fraught with falling between the cracks sort of ideas. And then finally, the expectation shift. Chronic means chronic, and it's long-term, and we shouldn't be thinking about how to provide a one-off intervention and then try and move that person along. It should be, the system should support the actual disease, the condition that it's responsible for helping in the way it's set up. So there's a bunch of these shifts that the supported self-management kind of idea moves towards. How do we do that? You know, as healthcare providers, when we go to work tomorrow or later on today, depending on wherever you are, you're not going to change all this. But you can take a leaf from the Motivational Interviewing book, which is really one of the kind of core ideas of this client-centered approach, and adopt a motivation interviewing stance in your work tomorrow. And that's what I want to just focus on a bit next. I've been teaching motivational interviewing for a couple of years now, and it sort of strikes me as a bit one of those things that it's a bit like people when they've had a bit too much to drink and they dance and they feel like they're dancing wonderfully well, but maybe it doesn't look so great. Motivational interviewing, everyone says they're doing it. We're all saying we do motivational interviewing, but how effectively we're doing it and whether it really embraces the spirit of MI is a different thing. So I want to just share with you a couple of ideas that all of us as healthcare professionals can implement, or at least try and implement, and see whether we can't get this supported self-management approach more integrated into our work. So the first thing is this notion of an expert trap. So MI recognizes that as healthcare professionals, we have knowledge, we know stuff. We've been training for a long time, been at university, we got all this knowledge. There's a real risk that we come across as the experts of that knowledge and we don't place the client or the patient at the center of our work. Taking that, falling into the expert trap means that we can either bamboozle our clients and patients because there's so much information, such complexity, such sort of sophistication to the work. They're not understanding, not following what we're saying. The expert trap can bore our patients, our clients, because there's just so much coming at them. It's not inspiring them. It's not getting them in any way engaged in the process. Or ultimately, it's not, the expert trap creates a passivity in a client, in a patient. Then they're not part of the process. They're being lectured at or talked at or given, and it's not going to engender a motivation for change, which is what, at some level, most of the work we're doing in this space, in supporting people with chronic back pain, is about trying to motivate change. So the expert trap is a problem. Motivational interviewing says there's a number of ways we can avoid stepping into the expert trap, and one of them is this technique called elicit, provide, elicit. And so that's what I hope everyone can give this a try. The next patient you see and see how this works for you. So what this means is, first one is you elicit from the client, from the patient, their understanding of whatever topic it is, whatever knowledge you're going to share with them. Find out firstly what they know about it. So before you launch off and tell them all about neuroscience or all about desensitization or what clever knowledge you've got, find out firstly what they know about it, because they actually may surprise you with how much they do know, or they might say, I have no idea what you're talking about. I've never heard that term before, in which case you can adjust your message. But asking them first up what they know about something is the first step to avoiding this expert trap. Second step is you provide information prefaced by asking permission. So you ask for the client's permission for you to share your knowledge, your expertise, your material on whatever this topic is, so in this case, activity pacing. So before you launch at them and tell them all this stuff, you get a mandate from them that yes, they're receptive, this is a good time to understand, they're ready for you to give them that information. And then the final elicit, you ask, so what do you make of what I just said to you? Does that make sense? How does that approach sound? So you elicit their understanding of what you've told them to make sure, again, that the messages they've received are the ones that you wanted to send, and they've got the right end of the stick, and that you're okay to proceed. So elicit, provide, elicit, as opposed to just telling them stuff, is a much better way, certainly to avoid the expert trap, but to engage your client, your patient in this sort of active process that is chronic pain management. Second one is you might have to do an assessment. A lot of us, the day ahead, next day you go to work, you're going to assess people. So you're going to have to ask them lots of questions, and that's absolutely appropriate. That's what an assessment is. But you can fall into the expert trap if you just ask question after question after question and don't give your client or your patient any feedback on your understanding of what they've told you. So MI says, try and give a reflection for every 2 or 3 questions you ask. And a reflection just simply is your understanding of what they've told you. So, okay, so pain it's constant, it gets worse at night, and you're taking paracetamol to manage it. Is that your understanding? So just giving a brief reflection so the client understands that you have got it correct, your understanding is accurate. And it avoids, again, that passivity of just answering question after question after question that can happen with assessments sometimes. And finally, the premature focus trap. That's, again, I think a bit of a risk for us who work, we work in pain management. You kind of assume that you know what the client's goals are, and you can assume that they're ready to make these changes, and assumptions are generally to be avoided. So just being mindful that you don't jump into narrowing down too quickly that this client wants to make these changes or get going with this stuff until you've had the client expressing in their language that this is the change that they want to make. Helps to avoid that premature focus trap. So how well are we doing with all of this? Supported self-management, really nice study from last year. Qualitative study looked at, interviewed 40 experienced physios and exercise therapists about supported self-management. This group of therapists really endorsed, yep, supported self-management for back pain is a very important, it's a critical element of care for helping people manage chronic back pain. But when the researchers in this qualitative study investigated a bit further about what were actually these clinicians doing in terms of the self-management content, it was pretty much just patient education. And as I said before, patient education without a context around it is talking at people. And talking at people, as we know, doesn't change behavior. In fact, it can do the opposite. So it's not just giving information. Supported self-management isn't just letting patients get on with things, leaving them to their own devices. It's actually not just listening either. It's an active intervention, but it's certainly not a replacement for services. So just to finish up here, conscious of the time, ideally, supported self-management is a bunch of things. It's an integration of organizations across a healthcare system. Connected up healthcare, what an amazing concept. But instead of people being bounced from one to the other, it's an organization that understands the needs of the individuals in it and collectively is responsible for the outcomes for those people. Ideally, supported self-management has a shared philosophy from everybody who works in that system, that person-centered healthcare is not only more effective, but actually a much more rewarding place to work as a healthcare provider, as well as being more valuable for the clients and the patients in the system. That shared philosophy is critical. I think supported self-management can include, I don't really talk about this, but can include monitoring outcomes, because of course we need to demonstrate what we're doing is effective, but outcomes that are meaningful to the clients and patients as well. Not just the researchers, not just the healthcare providers, but actually outcomes that matter to people who are in that system. And so I guess the question is, and really what I want to just flag up for us to think about today is that if we, as a health service, as a bunch of health service providers, focus just as much on how we deliver our interventions as we do on whether this intervention is better or worse than that one, if we thought more about how we deliver them, maybe the next Cochrane review that comes out will see an uptick in findings, because we're not worrying so much about the what, but we're getting the how sorted out. And that's what I think supported self-management involves. Okay, I'll leave it there. Thank you very much for your attention.
Oh, thank you so much, Toby. It is just fascinating to think about supported self-management. And it's a great lead into our next speaker, Katie Napton, who is a physiotherapist. And I just love the way that healthcare is changing because of COVID, and the fact that we now have to think more about our language and our practice and being able to help people help themselves. And Katie is a physiotherapist and is doing a bit of online physiotherapy treatment programs. And I'm really interested to hear about your take, Katie, on supported self-management and how that's helping people. So over to you, Katie.
Thanks very much, Trevor. Just let me get my slideshow up. Okay. There we go. Right, yes. So I am doing supported self-management for back pain, and I've sort of focused on the made simple. So thanks for the introduction. Yeah, so I am a physiotherapist. I've got 30 years experience working in the musculoskeletal field. I've worked both in the NHS, our public sector, and more latterly in my own private practice. In 2016, I also set up an online physiotherapy clinic. So that is, I've got a team of experienced physios treating people via video, and this is pre-COVID, so a little bit ahead of the game, which has been really fascinating and interesting. So I have quite a mixed client load, but I have treated, quite a number over the years of persistent pain sufferers. We tend to use the word persistent quite a lot in the UK, trying to escape that sort of chronic phenomenon. So my disclosures, I have nothing to disclose at all. So when I thought about this, I thought, what do people want to go away with? And as I said, I've got a bit of a principle of keeping it fairly simple. So I wanted people to go with some tips. So if they're a clinician, what they need to think about and perhaps review, and things that either I've learned or I like to reflect quite a lot in practice. I quite often record intervention with clinicians, obviously with their permission, just to see how I could do things better. So I want to think from the clinician's point of view, what you want or what you should be doing. And then I've also thought from a patient point of view, what actually is a good interaction with a clinician. So from the clinician point of view, these are my sort of 5 things to think about. And apologies if it's teaching people to suck eggs, but I think we can always improve on our skills. So that initial one, which ties in with what Toby was talking about, is those listening skills. Always reevaluate, always think about, and I'm going to go into that a little bit more. Believe. Okay, believe in your patients. It sounds so obvious, and I feel slightly embarrassed putting it up there, but it comes up time and time again with patients that they don't feel that whoever they're seeing actually believes what they're telling them. To understand. So you need to understand your patients. You need to get it. You don't need to, you're not necessarily going to totally get it, but you need to get that bigger picture, how this is affecting their lives. And if you're telling them information, they need to understand you. So I put to understand and be understood. That importance of team working. So recognizing a clinician, perhaps if it's out of your depth, if you need a psychologist involved, if you need an occupational therapist involved, if you need to try and get this person onto a pain management program, it's recognizing potential limitations. I mean, I work now in the private world, and it can be more complicated. I'm often having to phone GPs, and it can be quite a battle to get that wider team in, but you may well need that. But it's also recognizing that you need to get a team built up for that patient. So they may need, you know, their partner more involved, their friends, their family, you know, everybody needs a bit more support, and it's recognizing that. The importance of goal setting. Now, you know, way back when I trained, goal setting was very much, you know, all range of movement, and it was very specific to our physio skills. But it's recognizing with these patients, they've got long-term problems, and it needs to be functional and relevant to them. And they need to know about them, because actually they're the ones that need to set them. And again, this sounds obvious, but it quite often doesn't happen. From a patient point of view, what does that patient want? They need to be listened to. Be believed. I don't think we're asking much there. You know, as patients, when you go to something, you want to feel that, yes, they've heard my story and they believe me. So you want them to understand that bigger picture, how this has affected your life, their lives, their work, their social life, how they're feeling, their mood, all of that needs to be taken into account. You need to be introduced that you need your team, okay? The supported self-management means that you need help, and it's to recognize you need to have those conversations with your partner, with your friends, and hopefully whoever you see can help introduce that fact to you. You can't do it alone. And recognizing that you go away with some joint goals, that you may have had some help from the therapist setting, but they are relevant to you as a person, and you can relate to them and understand them, and you get them and you want to achieve them. So the listen more. So actually, yes, so Toby talking about motivational interviewing is part of what I think. So we know that when someone goes to see a doctor, they're usually interrupted within 11 seconds. And actually, there's a more recent study that showed the more experienced physiotherapists actually interrupt people quicker than a newly qualified physio. So we really need to sit back, zip it, and listen. And I don't mean listening like you see on the telly, isn't it? And you see they film them in separate ways and they're going, and nodding their heads. I hate that. But it's actually actively listening. So you're engaging with the patient. So yes, you're letting them talk, but then you're relating it back. So you then might summarize, so they know that you've heard them, and they also know that you've understood. And as a clinician, it confirms that you have understood them. Now, sometimes you need to use some motivational interviewing skills because we don't want them sort of harking back to some bad times. We need to move things forward. We need to progress the conversation. And also, we do have limitations on appointment times. So when I was working in Australia, actually, and I treated a lovely chap, and I said, oh, well, you know, tell me all about it. So he goes, in 1944, when I jumped out of an aeroplane, my parachute didn't open. And I thought, right, okay. I mean, and it was fascinating. And he had the most amazing stories. And he was a prisoner of war, and he wrote a book, and I've still got the books to this day. But we did need to move things, you know, a few decades on to find out a little bit more about what was happening now. So it doesn't mean that you sit back and let them talk for hours on end. But, you know, you need to know that you've got that relevant stuff, and you've heard them, and you've listened. So the believe, yeah, I think we do need to emphasize this because it crops up again. I see in social media, you know, people with persistent pain saying, you know, no one believed me for years. What do we as clinicians want patients to go away with? Well, we want them to walk away going, do you know what? That is the first time in 6 years someone has A, listened to me, and B, understood and believed me. And as a clinician, if someone walks away from your appointment saying that, then, you know, that's a big tick in your box, and it can be a start on a really successful journey for that patient. Barriers. So in the medical profession, language seems to be our major barrier. And I think we need to be really careful. It's very easy to medicalize things We have nice, complicated names, and normally more than one name for different diseases. We also, just tend to compartmentalize people. We've got acronyms. I mean, the whole thing's really confusing. I spent a bit of time as a governor at my children's school, and teaching also has a whole different language. And actually, it's pretty overwhelming. We also need to be careful because some poor patients have been in that, going round in circles, had lots of investigations. And sometimes when you say, tell me about it, they go, well, I've got an L3-4 degenerate disc, I've got a L3 prolapse, I've got a right-sided S1 nerve irritation. And so you need to just, let them say that, because that's what they're carrying with them. But you need to really get down to the nitty-gritty of actually, what does that mean? Is that relevant to what you're suffering now? You need to talk about degenerative disc, but no, it's not a crumbling spine. It's like wrinkles in our skin. It's just, things do age in our body, and that's actually okay. And so you need to do that, but we also need to be careful not to bring in more complicated medical terms. We need people to understand what we're talking about. It's a really tricky one, and I think it's really important. And language, you just have to be so careful with. And in the pain world, pain's complicated, but perhaps we need to introduce, I was thinking perhaps actually earlier, rather than before patients, present with persistent pain, we need to have that conversation about pain. So we know you can get nociceptive pain, so you get injury, you get localized injury, you get localized pain, and that is due to tissue damage. But it's also not always relevant to the amount of damage, and perhaps we need to introduce that much earlier. And then also that concept that pain isn't always related to damage. So let's get those conversations going. So, we could go down causalogy, predictive processing, and all these wonderful pain stuff if someone's really into the science of it, and that's great. But let's start these easy, basic conversations about pain and put away, the fear factor. And so that that the patient has understood and you understand the patient. It always seems to come back to that. Let's not confuse them. Okay, so you think you've done a fantastic session. Oh, yeah, they've got it, they understand it. Let's, let them go away and sort it out. They need to know exactly. So I had a wonderful, very intelligent patient who'd had 20 years of back pain history. We had the conversation, we did the video. So yes, the Pete O'Sullivan, the Lorimer Mosley, all those fantastic pain information videos that lots of us use. But I know it hadn't quite clicked. And he went away and he was doing some DIY, and he went to pick up his electric drill. And then as he picked it up, he realized that he had wet hands and he felt an electric shock. And he thought, oh, that was bad. And then he looked at his drill and it wasn't even plugged in. So that's when he got it. So he got that you can have stuff without it actually being something. So it can be, maybe it's using metaphors, so that car alarm that just goes off for no real reason. It's finding the way into that patient that they understand. And quite often what's useful for them is perhaps to record a bit of the session or just do a little summary so that when they go home, they can listen to it. Or if their partner says, well, what did they say? They can play it, because it's frightening what people take away. So what we think they've heard and what they've understood is totally different. And I think it's just so important that we check that we get that nice message through. Teamwork. So as I said, and in terms of clinician, I think it's vital that you recognize your limitations, and where possible, you bring in that wider team. But also thinking from a clinician point of view, you may need a support network, because actually it's quite draining treating long-term illnesses. So you may need a peer group, you may need a psychologist that you can have a chat with. I think sharing some of these experiences, offloading a little bit, will make you a much better clinician. But also you have a duty to check that the patient recognizes that they need a team. This isn't a go it alone stuff. you need support because you're going to have setbacks, you're going to have blips. Recovery is always up and down, and supported self-management is an ongoing process. So once you've got that team, you've got that lovely support network. And as Toby mentioned, you know, the online world now has opened up this huge opportunity. So you've got access to a large group of fellow pain sufferers, and you can dip in and out or choose one that suits you. They can vary in what appeals to you, but you know, find one that's positive, and you may well then make really good connections that can help. Again, it's not that one-way street, is it? It's the therapist does this magic hands trick. I go away, I feel a bit better for a couple of days, but then I need to go back to them. It's two ways. And actually, you know, you're the most important person, all right? You're driving that car. So you have a therapist that helps you, and if they're not helping you, drop them. And you're the one in control. So never feel that the therapist told me to do that. It's got to be a mutual thing, and it's got to be around what you need as a patient and what you're suffering from. So my sort of top things are, as a clinician, to me, listening is our greatest tool. And if we're not listening, what are we doing? It's quite frightening. But please, you know, as Toby alluded to, look up the Motivational Interviewing, get the book, look, you know, there's lots of information out there, but do what you can to improve your listening skills and stop and zip it. I do have to remind myself sometimes, I have to reflect that, you know, there are times I could do better, my communication could be clearer, and listening is the primary one. So just stop. Have I let them speak? Don't time yourself, because that's not good, but just check that you're listening to what they're saying. Belief. Now that's essential to get a really good therapeutic relationship. If you don't believe your patients and your patient doesn't feel believed by you, it's not going to go well. Talk the same language. Now, if that person has got a science degree and is into pain, absolutely have those discussions. Fascinating, you know, it's really interesting, and there's lots of stuff we're still learning. We don't know it all, so you know, it's great to have those conversations. But if they don't want to go there, don't go there, and check that they understand enough or what they need to make them move forward. Support is vital. All right, without support, self-management, is not supported self-management, and it's not going to get where you want to. And build that team, and the team can move, it can change, but you just need to know there's a support network around you. So we've got a beautiful team, we're all heading in the right direction, and we're rowing to make the boat move. So to me, supported self-management it's hugely exciting when it's done well, and it opens opportunities and enables people to live fulfilling lives. And that's the end of my talk. Thank you.
Wow. Thank you so much, Tanya. Oh, Katie, I should say. I just love one of your points there of listening, being real, authentic with people, and really hearing their story as the starting point. So I really thank you for that. And before we jump into Pete, I just thought we might stretch a little bit. I'm going to move my arms and wiggle around a little bit, and because we've been going full on for about an hour or so. So it's great to be able to move and relax and really concentrate and hear. Pete, I just love that you were able to pull this webinar together and get some different people from around the world that share your passion for self-management. And I love the fact that you've been able to use your experience to reflect on what makes a difference in people's lives. And I just noticed that there was a bit of commentary coming through on the Q&A around terminology, and Katie was looking at terminology and language, and do we call it persistent pain or do we call it chronic pain? And for me, we've changed the focus from chronic, which has a tone of you're stuck in this state forever. It's a disease. It's not going to go away. To persisting pain, which is that pain that is really quite annoying and keeps going despite the fact that our tissues may have healed. And this is where self-management really comes into its own in my mind. And I'm quite happy to hand pass across to you, Pete, now, because I'm sure you're going to talk more about how important self-management is to people that are living with persisting pain. So thank you very much.
Well, thanks, Trevor, and welcome everyone, and thanks everybody for joining the webinar. I think you're really cool. This is the place to be to learn some simple tips about back pain. And as the title there goes, what I want to do today, just short presentation, is to give you some really simple ideas about managing back pain. Whether you're a healthcare professional watching or if you're a person living with back pain, I'm going to share these tips are both for you guys, okay? But before I start, I'm going to ask you a quick question, okay? So if you're a healthcare professional, is back pain self-management your first choice or last resort? If you're a person living with back pain, is it your first choice or last resort? And from talking to people over the years, healthcare professionals and people with back pain, it always seems to be the last resort. And what we need to be doing is over those conversations from the get-go. Don't leave it until it's like a fireman, isn't it? Waiting for the see some smoke in the house, and then, well, I'm not going to do anything about it until the actual buildings goes on fire. To me, that's totally bonkers. So really, we need to start having those conversations from the get-go and not leave it to the last. So listen, just stay tuned. I'm going to give you some really simple ideas here about back pain. Disclosures before I do the kick-off. I'm the originator and author of the Pain Toolkit, and I work as a consultant with Teesside University doing educational virtual reality stuff. So that's the sort of stuff we're working on doing educational workshops for people with back pain using VR. So let's get cracking. So this is, I love this quote, this lady from London, FF. She said, the back pain doesn't go away, you just have to make room for it. And you know what, that's what I had to do back in the day, because me, I was a doctor shopper, therapy shopper, looking for the fix, like, anybody with an historyology after their name. I was there, I spent about £8,000 on British pounds on trying to find the magic bullet. Trust me, there isn't one, But what there is back pain management, and I'm going to share some tips about that now. Most people with back pain, after 3 months or so, becomes just the tip of the iceberg, really. And these are the common problems that people tell me that they have to also deal with: sleep problems, money worries, medication side effects, feeling low, stressed out, relationship worries. Hey, listen, they're just a few of them. But what I suggest to what I suggest to healthcare professionals, that once people have had back pain for longer than 3 months, these problems here actually supersede the pain itself. So in a way, it's a little bit back to front thinking, where sometimes to wind the back pain down, is we need to think about how do we deal with these things. So it's where healthcare professionals and also people with back pain, they need to start learning some other skills as well. I'm still sleeping bad, so what can I do to get back to sleep a bit quicker? And as Toby and Casey have been talking, I know Bonnie's going to talk about it as well. It's teamwork. Back pain self-management is teamwork. It's not a one-way street, as Katie said. It's got to be a partnership going on there. So this is a really handy tip, okay? Because I like to think back pain self-management or self-management, it's really, I think you have to put your educational hat on, okay? So, when we go to go and see the healthcare professional, 9 times out of 10, we walk out there with a leaflet, Well, I'll tell you what, if you know, if you're like me, I'm not a learner from reading. I can read. Trust me, I can read. I read the meter every day, actually. No, you know, reading ain't my strong point. I don't get, you know, I'm a visual learner. So if you're a healthcare professional, what do you need to do before you give someone a leaflet is actually ask them, how do they learn? They learn from watching, you know, videos, stuff like that. Other ways of watching. I'm trying to think of other ways of watching TV or whatnot. Reading. Are they readers? Do they learn from listening? Or do they learn from practice? Or is it a combination of the above? Now, if you're a person with back pain watching this webinar, you need to, you know, this is where you need to step up. You know, it's that partnership thing, and actually say to the healthcare professional, hey, you know what, you know, this leaflet, I'm not really a reader. Can you give me information I best learn from? You know, then you know, it's partnership working. I remember when I got diagnosed with prostate cancer coming up 5 years ago now. You know, they sent me out with a booklet. It wasn't quite like a telephone book, but it was quite a thick booklet, you know, from the Royal Society of Urology. You know, it's all medical stuff, mate. I've never been to med school. So what did I do with it? That didn't last long. That went in a bin, like. So, but because I've got these skills of self-management, I went online and started looking for information. So very, very important that when you're seeing people, is that you ask them how they learn. They watchers, readers, listeners, or they learn from practice and stuff like that. As I say, it could be a combination. Now, 5 key coaching or back pain self-management skills. Who come up with these 5? I'll tell you what, it ain't me. These are, I've been doing this job, you know, I've been involved with self-management for quite a few years now. And over the years, I've been talking to people about, well, how do they manage? How do they self-manage? And these are the 5 key things here that they told me that they learn from. So I think Katie talked about it, mentioned it earlier on about goal setting and action planning. Now I quite like that because I remember I worked on another program years ago, and it said on the in the literature and whatnot, if you don't know where you're going, it's unlikely you're going to get there. And that's why people with long-term back pain, we need to aim for something. Like, we need goals. And when I was on my pain management program way back in '96, we was asked to set goals. We set short goals, medium goals, and long-term goals. So, you know, to me, goal setting, action planning, how we're going to reach those goals is very, very important. Pacing our daily activities. Now, I'll tell you what, not a lot of healthcare professionals actually know what pacing is. You know, because when I'm doing workshops with them or when I'm face-to-face stuff, I always ask them, what does pacing mean? And I get very, you know, they're not entirely wrong, but they all get some different answers. In pain management land, this is one of the skills that I learned on my pain management program. Pacing is taking a break before you think you need to. Because what a lot of people do is we let our pain be our guide. So we'll keep going. And when the pain starts to increases, we think, oh, okay, I better stop now. Well, that's not pain management. That's the pain managing you. So pacing is taking a break before you think you need to. How I explain it on the workshop, simply it's like this. If you're a car driver, okay, you're driving along the road there, and you look at your petrol gauge or your gas station, wherever you are, you say, oh, I'm running a bit low. I don't want to run out. So what I'm going to do, I better look around for a petrol station or a gas station to refill. Because if you run out, you're really in problems then, because that means that you've got to get a tow truck out, or it's got to pay someone to bring you some fuel and whatnot. So in that terms there, you're actually stopping before you get into problems. Pacing is exactly the same way. It's about taking a break before you think you need to, but you need to work out a bit of a baseline. So let's take walking for an example. Let's say from 0 to 100, you can walk from standing still to 100 meters. So you can say it gets 100 meters, and then your pain starts or increases. You need to stop and take a break. From 0 to 100 meters, it's how far you can walk before your pain starts or increases. So chop it in half, reduce everything by 50%. Everybody knows what half of something is. So stop at 50 meters, take a short break, have a sit down, or if you're window shopping, just look in the window and then walk the other 50 meters. You've now actually walked 100 meters, but your pain hasn't increased. Same thing with gardening. Work out how much gardening you can do. So you can do 20 minutes before your pain starts to increases. So easy peasy lemon squeezy, chop it in half, take a break at 10 minutes, come indoors, have a cup of tea or coffee or whatever, then go back out and do a bit more. You'll find that you'll be able to do more throughout the day. And guess what? Your pain won't go up. Easy peasy. Problem solving. Hey, listen, everybody gets problems in life. Me too. But it's about learning problem solving skills to get around that. It's like me going out my van today and driving. I find out there's a traffic jam. You know, what am I going to do? Sit in a traffic jam all day? Of course I'm not. I'm going to find another route. That's problem solving. It's about finding, solving problems, that, you know, little speed bumps that we get in life, etc. Keeping active, meaningful movement, stretching, exercising. A lot of people with pain, we fear movement. We fear stretch. You know, when if someone says to you, start stretching, exercising, it's like running for well, we wouldn't run for the hills, but you get frightened. You know, because when you've been active before, your pain has increased, and who wants pain? So it's all about, again, it's like pacing. Use that in getting active and movement. The thing is, there, see, I put in there meaningful movement. It's about moving, doing things that you like doing. You know, for some people, maybe dancing. You know, not too crazy dancing, like the jive or whatnot, but just simple movement. But that things that you want to do, could be a little bit of gardening, walking, etc. But keeping active. I mean, listen, I'm not trying to be a big head here, but I've, you know, since I went on that program in pain management program in '96, and I was taught graded exercise, paced up exercise. And since '97, you know what? I've not had to take any pain meds. I stretch and exercise every day. I keep moving, etc. For me, not moving. For me, it means I've got to go back on the pills. And do you know what? I don't want to do that. Knowing what to do if something goes wrong. You know, it's having a setback plan. Listen, you know, we're all going to get. We're overachievers, us lot. We want to keep up with everybody else. So the chances are we're going to overdo it. We'll have a setback. So we need a plan. It's like when you're out in your car, say getting that traffic jam there, have another plan, see what happens. Or if you get a puncture in your tyre, you know, you put a spare on so you can carry on with your journey. So having setback plans, very, very important. And all these ones here come up, all these ideas come up not from healthcare professionals, but from people living with long-term back pain. Get it? Yeah, good, etc., etc. So this is a bit of an example of back pain self-management. I love this term, self-management living. Okay, I don't focus on my back pain anymore and all the other health problems I've got as I've become an older person. I'm really interested about self-management living for me. So these are some of the things that I've come up with: goal setting, action planning, things I've been going on about, problem solving, keeping active, having a setback plan, being resilient. Now, I've only just been using that term the last couple of years, but I've got it from I've got that term from my buddy over there in Canada, Keith Meldrum, and I think he actually got it from you, Bronnie. So it's great. I love all this stuff out. It's all passed around, but being resilient, you know, it's not about toughening up, but we've got to hang in there, like, you know. And you know what? I always say to people, if I can do back pain self-management, I know you can as well. Self-management living, I really dig it. Hey, listen, we don't need no heroes here to manage your back pain. You just need a plan. Okay, keep it dead simple. Keep pain self-management simple. You can't go wrong. Here's some quotes here from a couple of people that have been on the program over the years. The back pain toolkit workshops we run here. You know, lady there, a lady from Norfolk, she wanted to remain anonymous. You know, a lot of people, we do go doctor shopping and we spend endless amount of time on wanting to be fixed. And I was like that years ago. It wasn't until I remember one morning I woke up and, well, it was my birthday on 31st December 1950. No, on the year 31st December. and I couldn't see any future for myself. And I thought about, ending my life, And the next day I said to myself, I think, who's going to get me out of this mess? And I was in there having a shave, and I thought to myself, that's me. I've got to get myself out of this mess. That's why I'm passionate about self-management, pain self-management, because I don't want people to end up like me, thinking about harming themselves and anything like that. Going on Pete's back pain toolkit is one of the best things I ever did. This term confidence, I like about that, because a lot of people with back pain in general, or even long-term conditions, you know what? We lose our confidence. And it's about when we start regaining our confidence again, hey, watch out, we're rocking and rolling, baby. We start enjoying life again. So I just wrote this out this morning. Note to you, yourself. Check out more of the back pain self-management skills. Come and check out the pain toolkit, and be groovy like me and many others out there around the world that are self-managing their back pain. There you go. That's me done.
Oh, thank you, Pete. I'm just going to sit with some of that, because your message is so practical, and it's stuff we can do today. It comes from here, from your heart. It comes from your own experience, and you've managed to be able to craft together the important elements of self-management and why it's so important. Because at the end of the day, we're in control of our own destiny. We need a team approach. Pain's complex, but with the right people around us, we can take control and get on with living. And I just love that concept. It's not pain self-management, it's pain management. It's living. And it is getting your life back. And it's a very good segue into our final speaker, Dr. Bronnie Lennox Thompson. Bronnie, I love your work. I'm a big fan. If I came back, I'd want to be an occupational therapist. When you marry occupational therapy with psychology, when you bring together your own lived experience and craft together the thoughts about self-management, it's a powerful message that you've got. I'm all ears, and I can't wait to have you finish off the panel, and then we'll get into some questions. So thank you all the way from New Zealand.
Kia ora tātou, and yes, I'm in the sunny Northland, so I'm in the north of New Zealand. I usually reside in Christchurch in the South Island, and we're a long, skinny country, and it's a whole lot warmer here than it is down in Christchurch, where it's just getting a bit, autumnal. We've got the crisp air and stuff. So thank you so much for the opportunity to share some of the ideas that I have from my experience as an occupational therapist. I'm just going to share my screen, and she says on my little tiny screen, and then I can start off. Here we go. So I want to talk about an occupational therapy perspective on living with low back pain. Disclosures, so I have a tenured position with the University of Otago in Christchurch. And so my job is essentially teaching postgraduate pain management, and I work with I'm the academic coordinator of our postgraduate programs in pain and pain management. I write a blog. It's unfunded. It's a labor of love. Got to be love, because why else would you do it for 12 years now? And I do offer some online training to clinicians for a self-management program that I run, and some other clinical skills training as well. You'll see me all over social media. So what's our goal in low back pain management? What are we trying to achieve? And what I hope, so I live with fibromyalgia. I started with back pain. And my hope, when I was seen way back in the early 1980s, was that I would be able to get back to my life. And I hope that when we're working with people, that we want to help this person resume their life with as little disruption as possible, and perhaps even to flourish, because we learn from everything that we experience, and that can help us become more capable, more adaptable, and more willing to be able to try things, new things. The question is, how do we get there? And I have this experience, this feeling that sometimes as clinicians, we are trying to get people who are square pegs to fit into our round holes. So we say everybody must do X because I like it and I think you should do it. And frankly, if you tried to do that for me, you wouldn't get the nicest response. That's all. So here's a disclosure. As an occupational therapist, I'm trained in both physical and mental health care. Not many people know what an occupational therapist offers. And so that's partly why I wanted to talk about this. We use a whole person approach. We always have done. So when we hear now that a biopsychosocial approach is really good for pain management and that a whole person approach is crucial to occupational therapists, this is fundamental to the way that we work with people. And our professional expertise, and I'm trying to make this kind of simple, it's my elevator speech, is that our expertise lies in looking at context. So the environment, the people, what you want to do in your life, the habits, the routines, the occupation, things that you do that are meaningful to you, both as therapy and as the outcome of what we do when we're helping to work with somebody. And I want to say that nothing that I do can't be done by somebody else from a different profession. So a physiotherapist can do an awful lot of what I do, and a psychologist can do an awful lot of what I do. And what I see very often is a psychology physiotherapy pairing. And so I wanted to push a little bit of an agenda here. But also everything that I do is based on research from a broad range of knowledge domains. So occupational therapists tend not to publish a lot, which is probably why we're not very visible in this self-management and pain management scene. And so I wanted to answer the question of what does an occupational therapist offer? So what we do is we do doing. Let's call it that. We do doing in the context of somebody's own life. In other words, we're knowledge translation experts. What I do is help people say what they've learned in somebody else's clinic in their world. For example, if you're taught to lift something in a physiotherapy clinic, I'm saying, so, and how can you manage to put your groceries in the back of your car? How can you hang out your washing? How do you manage to pick up that 2-year-old that's squirming and doesn't want to have their nappy changed? And some of the major limitations for most therapy for persistent pain, and remember this is my bias, is that there's very limited generalization of things like graded exposure into new and different contexts. And that means that people don't know how to say, when I walk over this rough ground, I am still safe. They know how to do it in a clinic, but they don't know how to walk in the slippery mall. So they go to the shopping mall, there's lots of people there, the floor is slippery, and they're scared. We also know that all of our pain management programs offer very limited long-term change. So people change quite quickly, immediately through the program, but then those effects fade. It's hard for people to integrate doing these new strategies into daily life. And all of our treatments have these teeny tiny little effect sizes. That's across the board. We need to be really honest about that. Exercise is fantastic, but the effect size on pain intensity and disability is actually tiny. However, individuals can report really good impacts for them. So people have this need for unique material that works for them in their life. And I also want to put a pitch out here that behavioural aspects of therapy, the doing, the experiential part, have the greater impact on how people think about their pain and how they experience it than just giving some information. As Wilbert Fordyce said, information is to behaviour change as spaghetti is to a brick. Doesn't move the brick much. So what I do is bridge between the clinic, wherever your therapies are undertaken, and your world, if you're a person who lives with pain. So we have this biological, structural, diagnostic, movement, strength stuff, including medications and surgical procedures and other procedures, exercises. We also have all the stuff around thoughts and confidence and strategies, managing mood, anxiety. And this is where I fit, in the middle, integrating, individualizing, generalizing, contextualizing what this means for this person in their world, because it's not my life, it's their life. And I'm a person with pain, so it's my life too. But what I like and what somebody else likes is not necessarily the same thing. So how do I do this? So my preference, and I started working in self-management in 1987. So I've been doing it quite a long time now. And I've shifted only a little bit. So my preference is to look at what matters to this person, what's getting in the way of what it matters to you, and what supports your doing. I look at a 24-hour day assessment. So I want to know, what time do you get up in the morning? How are you feeling when you get up? Do you feel like you've had a good sleep? What do you do then? Do you get go and have a shower or a bath, or do you go for a walk? Do you get the kids out of bed? What time do you have your lunch? Do you have a lunch? And when you get home after a working day, what do you do for fun? Who do you mix with? What's your relationship like? Do you have intimacy with your partner? With an ACT lens on, I look for factors that might limit the flexibility with which somebody gets to do what matters. So somebody might have learnt that I must lift in a particular way because that's going to be really good for my back. But actually, I'm a plumber and I crawl underneath houses carrying my toolkit. Or I'm a mum who's got a 2.5-year-old who really doesn't want to get to in the car, and I've got to lift that kid and wrangle that kid into the back of the car. So I want to look at, can you be flexible with the things that you've learned? And can you be knowledgeable enough about, yes, what you do, but also how you do it, when you do it, where you do it? Have you got a repertoire that you can build on? And for clinicians, can we offer people choices? I aim to help that person choose from a repertoire of things that help them do what matters in their life in all those different contexts. For example, if I give somebody a lovely chair that they can sit in, but then they can't take that chair to work, or they can't take that chair out to watch a movie. We can watch movies in a cinema in New Zealand, just saying. Sorry, guys. But can that person use that strategy in their world? So what I'm really offering people as an occupational therapist is wiggle room. For those of you that don't know, this is a Chinese finger trap, and if you put your fingers in and you pull hard, it will only trap you harder. So what you need to do to get out of a finger trap, you need to go in a little bit and wiggle. And my use of that metaphor is that sometimes we need to go in and sit with and allow ourselves to experience pain, to be willing to allow your pain to do what it does, and to find little shifts. You might pick up a tip from one clinician, you might read something online, you might have a conversation with a friend, and each person might add a little bit that you can say, I'll take this little tiny bit and I'll add it to my life. In my PhD, I looked at people who live well with pain. This is what they told me they do. They never stop looking for something that will help. But if it doesn't fit in their life, they are not going to do it long term. And our job as clinicians is to say, how can we translate this theoretical stuff that I know into your world? So I want to know what helps you feel like you. That could be for some people that they start by doing something that is not about going back to work. It could be about connecting with their partner. It could be about being with their mates again. I seem to work with a lot of motorcyclists, and it could be about not feeling guilty because I've jumped on my motorbike, I went for a 3-hour ride, I got a flare up, and when I ask them, and was it worth it? They say yes. Is it okay to have some fluctuation in your pain if it means you do something awesome and cool and fun that builds up who you are? Because that matters. So my argument is use your occupational therapists. Context is our thing. Daily life stuff, hanging out, washing, cooking meals, doing the grocery shopping, going to work, surfing, riding motorbikes, that's what we're about. And generalizing and integrating these skills into daily life is our bread and butter. So if you're wondering, how can I help this person do this? Check out your OTs. Working with the whole person is our fundamental theoretical sort of perspective. And occupation, doing, is experiential. People do stuff, experience stuff, and learn from that. We call it doing, being, becoming, and belonging, because that's our professional background. And so how we help someone get to an outcome is going to be bespoke. It's going to be tailored to that person's unique needs. What matters to them now? Because when somebody first has a bout of back pain, their needs will be different from when they've had that back pain for 10 years. And that is an ongoing, growing, learning process that we sometimes forget and think that everybody needs to have this stuff that a curriculum that I'm going to give you. So this is about living well with pain, whether it's acute pain or ongoing. That's the end of my little chat. Thank you so much.
Well, thank you, Bronnie. Inspiring stuff. And when I think about all the people that I know that live with persisting pain, there is a bit of a common element about flexibility. Many of them are very rigid in their approach to life and thinking. Many of them, like myself, were fixated on finding the cause of the pain and that one thing to fix it. And I'm really interested, as a question for the whole panel, not only yourself, Bronnie, but for others to kick in, what are your thoughts about how you go about supporting people to become more flexible in their approach to life, relationships, social stuff, that emotional flexibility? Because at the end of the day, I think we're all in the business of creating change. And that rigid, inflexible approach is counter to really managing pain well and helping people to self-manage. So what are your thoughts on how to really foster a growing sense of flexibility in people?
For me, it's about recognizing that we've got sticky minds. The thoughts pop in, they stick there, and we believe them as if they're truth with a capital T. they're an opinion. And so, and remember who's telling you that this is the truth. It's your mind, and I don't trust mine. And I also think that we know that if you look at values and what is important in somebody's life, there are lots of ways to be a really good father. I work a lot with blokes, and when I ask, what's a dad to you, and they say, oh, it's rough and tumble. And then I remind these guys with back pain that actually it's more, there's more that you do. You sit with your kids and you listen to them read their homework to you, and you take them to their footy practice. So there's lots of different ways that we demonstrate being a really good dad. So part of looking this flexibility is thinking, what is it about this thing that matters to me, and how else could I do that? Instead of being stuck in thinking there's only one way to be a good dad or a good motorcyclist.
Ronnie, can I pick up on what you're saying there? Because Trevor, I have a PhD student at the moment who's looking at goal setting as a set of interconnected goals. We tend to think of goals as being a goal of being a good dad, goal of riding my motorcycle, goal of going back to work, whatever it is. But in fact, goals tend to be interconnected, and different goals relate to multiple outcomes. And so this idea of trying to speak to flexibility is very much, I think, helping people realize that there's multiple ways of getting to the same endpoint. It isn't just a singular way. And hopefully we're going to be able to come up with a program that allows people to see that and see for themselves that they actually have interdependent goals. And if that goal's being thwarted by something, maybe it's their pain or whatever, something else, there are other ways of getting to that same endpoint, which is really fostering that flexibility idea that you're talking about.
Yeah, no, I think that sort of feeds in with what I do, but also it's getting them to reflect that they're not achieving what they want to achieve, isn't it? That they've got that rigid mindset, and where's that got them? That's why they're there with you today. And perhaps starting from there and then trying to find those different ways to channel through and get to their goal.
Just going to butt in there. I think a lot of people, a lot of healthcare professionals think that their relationship with their their patient is like till death do us part. It's like a marriage, And the thing is, it's about giving people the lifelong skills, as I was given years ago. Hey, Trevor, I'm going to ask you a question. Do you drive a car?
Yes, I do.
Do you still take driving lessons?
No.
Why?
I know how to drive.
Exactly that. So so a healthcare professional needs to look at it that giving people the skills, the lifelong skills, as you did like learning to drive your car, it's about us getting on with it, but they can dip back in and again if they to their healthcare professional, if and when they're needed. But it's about moving on, don't be too reliant. I know where the healthcare professions are, if I get stuck and whatnot, but it's all about moving on, getting on with life, self-management living.
Yep. Very good. Very good. Yeah. Now, do we have any other questions there? I have. I'm interested in the relationship, that the part that values play, and what we do to help people understand values and how they might be able to use those in self-managing their back care and other aspects of their life. What are people's thoughts on that?
What did you mean by values, Trevor?
Well, the things that really matter to me, and I could go back to when I was in pain. I wanted to find a fix, and I valued any clinician that could say to me, "I know what your problem is, and I'm going to fix it." And I know where that left me. And then there was a transition to really valuing understanding pain and being able to do stuff for myself that made a difference. but sometimes the big decisions that we make in life are guided by what we really value. And if we understand them, it can give us a way of taking more ownership on our healthcare, and also how we do life.
The way I introduce values is say to somebody who's looking for pain reduction, so if pain wasn't such a problem for you, what would you be doing? Because it's underneath that we start to say, well, I'd be spend more time with my kids, or I'd be at work. And then we can ask the question, so why would that be important for you? What is it about that matters to you? And what will come out from there usually is something around, well, I want to be independent, and there are lots of different reasons that people like to do different things. I like to do silversmithing because I love creativity and expressing stuff, and it gets me out of my head, and not to be able to do that would be really hard. So, but I have alternative ways of doing that creativity, expressing myself. And I guess that's part of the way that I work with people. Say if a value is like a direction that I'm moving towards, moving in, being a good parent is usually a pretty good value. It's unlike a goal that you can tick off and say, tick, I've done that. Because if you say, oh, I've done with being a good parent, tick, you'll have child services coming after you, because, you know, then you can be the bad parent. You never stop being that person who wants to be a good parent. So values are about that direction, and goals are much more about the sort of actions and the steps that are kind of embodied doing that. So that, to me, that's about saying what matters in your life, and then why does that matter? And then my question is always, how can I help you get there?
Yeah, no, that's great, Bronnie. I just want to go back to a question that Rajesh Menon asked. How do you motivate patients in chronic pain? And the majority I've come across feel they expect instant relief. So, Toby, I might start with you. Just how do you motivate patients, perhaps towards more self-management?
That's a really common question, isn't it? Now, it's sort of that kind of reflects, I think, the frustration that a lot of clinicians feel when they can sort of faced with a patient who takes that perspective. My take on this is that very few patients are not motivated, or very few people with persistent pain are not motivated. The fact that that person's sitting in the room with you or online with you tells you a lot about they're motivated. But the role as the healthcare provider is to find a way of engaging their motivation in a direction that your evidence-based repertoire tells you is going to be helpful for them. So I think it's one of these myths about chronic pain, actually, that kind of pervades a little bit, that, you know, persistent pain patients, if people refer that term, are not motivated, and they're stuck, and they just want, you know, I think they're incredibly motivated, but they're often very stuck. It's like the wheels are spinning really fast because they're not getting where they want to get to. And our job as the healthcare providers is to push the analogy, but to put some chocks under the wheels so they can get moving. And that's not by confronting them or hitting them with a whole lot of, you know, neuroscience stuff. It's about engaging them in a process and helping them move towards, and I think sometimes the thing we miss, people's own experience. You know, if you've been chasing the cure goal for 5 years, what does that experience tell you how likely that's going to be? But, you know, that's done, I think that sort of stuff's done in context. It's very hard to, you know, can sound a bit flippant and a bit off the cuff when we're kind of describing this. Now, you've got a relationship with your client, with your patient by this point, and your therapeutic alliance is going to want to make the difference in having these conversations. It isn't a flippant sort of sentence that, okay, well, now they get it and away they go, they're motivated. There's a relationship and a trust that has to have formed, and then I think the chocks go under the wheels. But I'm sure you guys have got thoughts as well. I'll stop.
Well, for me, how I motivate, well, in a way, see, I've got a bit of an advantage over a lot of healthcare professionals, because I mean, I've been there, I've been where they are, you know, and I know some healthcare professionals, you know, that live with long-term pain, etc. You know, but it's, you know, they're using that term lived experience and stuff like that. But for me, see, I suppose in a way, I'm living proof that pain management, back pain management works. So really, but for a healthcare professional, I know it can be a struggle, like, you know, to how to motivate them. I guess really it's like someone trying to motivate me that it's okay to be bald, like, you know. You know, you'll be all right. You just have to learn to live with it, mate. Yeah, I want my long hair back. You know. The thing is, it's about that acceptance that you know, listen, I'm just a slaphead, and that's it. Job done, happy days, and moving on. You know, but yeah, I think, you know, it can be a tough call for people. And I get a lot of emails from people who are struggling, like they're asking questions about meds and whatnot. I can't answer stuff on stuff like that. But there's, like Toby said, they're stuck. You know, they're looking for the answer, I suppose, the key to the door that's going to sort of free them from that, you know, this burden they've got of living with this pain, like, you know.
Yeah, I think it's, I agree, it's that engagement, isn't it? It's finding, and it can be just the right time for that person when they're ready to move on and recognize that actually, you know, they don't want to live in that constrained life that they're living. And as Bronnie says, you know, they've got things they want to do and they want to be with their family. Although my teenage children, I'm quite happy to be in here. So escape, not a good parent. You know, so they've got to be at the right place. But hopefully, as an experienced clinician who listens and you've got that engagement with your patient, you can give them that opportunity. You can show that little window. But it's not, you're not going to get it right all the time. And, you know, and that's why there's so many people searching for answers still, because we're not getting it right all the time.
Yeah,
sorry, for me, that motivation, and I draw on motivational interviewing a lot. So for somebody to want to do something, it's got to be important to them. So if you haven't thought about what matters to this person, then you're never even going to be starting. And the second thing that matters is, are they confident they can do it? And if you make the goal too high, or you make the challenge too high, then, you know, why would somebody even have a go? And so we kind of sometimes think about self-management and pain management as they've got to do the whole shebang. There's lots of components to pain management. And so maybe it's not important for that person to learn to do this part. For example, going to the gym, for me, I would think that's not important to my life. I don't want to do it, so I won't do it. I'm very confident I can. But if somebody started there, I would be not happy. But if they said, hey, how's your sleep? That might be more important to me. So it's about us as clinicians thinking about, in this person's life, what is important to them, and then which strategy is going to help them, which set of strategies is going to help them achieve that, rather than thinking strategies first. Here's your strategy. I also found that in the research that I did, people look at their ideas of learning strategies only once they've got that idea of why they want to develop them in the first place. What do I want to be able to do? That kind of puts the learning strategies in place, and then people are much more likely to dig in and use them.
Yep. Yeah. Well, look, that's... Yeah, just looking at the time, I could talk about this all night. So, and I know that we're just scratching the surface, but one of the lovely things about this webinar, in my mind, is that it's opened up the conversation about how important understanding self-management is and what we can do to encourage people to take on more of an active role in treating their own pain. And no doubt, like you, Bronnie, I get a lot of my meaning from contributing in the online space and hearing what people have to say and asking questions and continuing the conversation. And this year, the Iasp is all about looking at low back pain, which is great. And so there's going to be lots of more learning going on. And I would encourage people to keep doing it. And I'm just going to hand right back to Jeanette now for her to wrap up.
Okay, great. So thanks everyone for joining us today. Before we close, I'd just like to inform you of some upcoming IASP programs. In May, we're going to have a free pain education course related to COVID-19. I would encourage all of you to sign up for this. It's free for members and non-members. And then after that, in June, we will be hosting our IASP Virtual World Congress on pain. We'll have plenty of sessions over the course of 6 days and lots of opportunities for people to interact with each other and view posters and things like that. And lastly, if you aren't a member, I would like to invite you to join IASP today, and we look forward to seeing you at future IASP programs. I encourage you to check out additional global year materials on our website. Thanks everyone for joining.